So we're going to the next topic, which is on portal hypertension. Okay, which is going to be on portal hypertension, one of the important topics which is less focused by many other apps and many other faculties. I'm going to discuss in depth about portal hypertension now. Okay, we're going to discuss portal hypertension in depth. Very interesting and important topic. If you understand the anatomy, you will answer all the questions in this. It's very simple and clear-cut anatomy. Just next 1 hour, please focus on this topic well. So please understand the anatomy which I'm going to now tell you. So this anatomy I'm going to show you one picture. This is superior mesenteric vein, which is carrying blood from the entire GIT. Just I'm drawing a rough diagram. So which is carrying blood supply from the GIT. From portal superior mesenteric vein is carrying blood supply from the midgut. The digestive food, which is all the energy is being carried by this superior mesenteric vein. It joins with the splenic vein. Please understand this image. If you understand this image, there is nothing in portal hypertension. And this is spleen. That is spleen. So splenic vein and superior mesenteric vein join together and form portal vein. So portal vein is 5 to 10 centimeter length. It is 5 to 10 centimeter length. In 5 to 10 centimeter, it divides into right and left and enters the liver. And it enters the liver. And inside the liver, it divides into multiple sinusoids like this. And from there, it drains into the hepatic veins, which all of you very well know. So right, left, middle, hepatic veins, it drains, and that enters into the IVC. This is the IVC. So please remember, this is IVC, which is carrying the systemic circulation, IVC. So this image you should never forget. You should never forget this image. So the one which is drawn in light blue color are known as portal circulation, and which I am now drawing in dark blue color are carrying the systemic circulation now. So they are all going to carry the systemic circulation, and this is the liver. So inside the liver, this is the liver. Just I am drawing roughly, this is liver. Now there are many causes of portal hypertension. To know portal hypertension, please remember the normal portal vein pressure is 5 to 8 millimeters mercury. So please remember the normal portal vein pressure is 5 to 8 millimeters mercury. It is just 5 to 8 millimeters mercury in the portal vein. Okay, and now what are the causes of portal hypertension? The causes of portal hypertension is actually a medicine question, but let me tell you, I will make it as very simple. Sinusoidal causes, pre-sinusoidal causes, post-sinusoidal causes. Very simple classification. You can write out easily the causes of portal hypertension as pre-sinusoidal, sinusoidal, post-sinusoidal. Sinusoidal is the most common cause, that is cirrhosis of liver. That is the most common cause of portal hypertension. Because of cirrhosis, there is fibrosis inside, so the portal vein blood will not flow properly. That is the most common cause. So that is sinusoidal. And coming to pre-sinusoidal, intrahepatic pre-sinusoidal. I'm further dividing it. Intrahepatic pre-sinusoidal and extrahepatic pre-sinusoidal. Can you tell me what is the most common cause of intrahepatic pre-sinusoidal? It is not seen in India. It is cystosomiasis. It is intrahepatic pre-sinusoidal is cystosomiasis and non-cirrhotic portal fibrosis are the two important causes. Pre-sinusoidal, intrahepatic pre-sinusoidal are cystosomiasis and NCPF. Extrahepatic causes are extrahepatic portal vein obstruction is one extrahepatic cause. Another cause is left side portal hypertension. I'm going to discuss everything in detail later. Just I'm giving the classification. Left side portal hypertension, also known as sinustral hypertension. Sinustral means left-hander. Sinister is a person who uses his left hand. So sinustral is left-sided portal hypertension. EHPVO or extrahepatic. Pre-sinusoidal, intrahepatic, extrahepatic. Post-sinusoidal, similarly we have intrahepatic, extrahepatic. Post-sinusoidal also we have two. Intrahepatic is known as veno-occlusive disease. It is known as veno-occlusive disease. Extrahepatic is what we say as Budd-Chiari syndrome. Involvement of obstruction of hepatic veins and IVC. Budd-Chiari syndrome is compression or obstruction of hepatic vein and IVC. Veno-occlusive disease is a obstruction of sublobular venules. Sublobular venules are obstructed. So I'm going to discuss everything in detail later. Just remember the classification. The most common cause in this list is cirrhosis. Sinusoidal, the most common cause is cirrhosis. Please don't forget this. Pre-sinusoidal, most common intrahepatic causes cystosomiasis. Intrahepatic pre-sinusoidal is cystosomiasis. Please don't forget this. Now just think of this picture here. Now the pressure is increased in this portal vein now. So naturally what will happen if the pressure in the portal vein is increased? There are some places where the portal vein is connected with the systemic vein by means of collaterals. The collaterals will now open up and result in problems. The collaterals are one important collateral going from here to the lower part of esophagus. Can you tell me what is this? From here, this vein is known as left gastric vein, also known as coronary vein. This vein is known as left gastric vein or coronary vein. This is from portal vein. This forms a collateral with the accessory hemiazygous vein in the lower border of esophagus. In the esophagogastric junction level, this is a high-yield anatomy question. Please don't forget. So there is a collateral formed between left gastric vein and accessory hemiazygous vein. Not azygous. It is with hemiazygous vein. So this is the first important collateral. Because of the back pressure happening here, what will happen? If there is a back pressure happening here, the left gastric vein will open up into the hemiazygous vein like this and result in the formation of the clinical features of portal hypertension are number 1. This is one feature that is known as varices. Esophagogastric varices. Number 1. Esophagogastric varices. Clinical feature number 1. So what else will open up? So this is splenic vein. From here, what vein is joining the splenic vein? Can you tell me what is this vein? This is inferior mesenteric vein, which will end up finally, after giving many tributaries, it will end up as superior rectal vein. So superior rectal vein is from portal vein, and middle and inferior rectal veins will join here, and they will become enlarged, resulting in hemorrhoids here. They will have hemorrhoids. Opened up. So hemorrhoids will open up. And from the left side portal vein, there is one vein going like this towards the umbilicus. Can you tell me what is this vein? There is a vein coming from left portal vein towards the umbilicus known as, that is a left umbilical vein or paraumbilical vein. So at birth there are two arteries and one vein. What is the one vein left? That is this left vein is left. So please remember embryologically the vein which is left umbilical vein. That vein will now open up and form caput medusae. So the features I'm telling you based on the clinical features. So that will form one feature known as caput medusae. Similarly, other raw areas like bare area of liver is one more area for collateral. Retroperitoneum is other area for collateral. And what are the other clinical features means if you see there is a big pressure extending towards the superior mesenteric vein and that is exerted on the bowel and it will result in ascites. That will result in ascites. So please don't forget what are all the clinical features of portal hypertension are. From this one picture you can tell out all the clinical features. Yes, tell me. Esophagogastric varices number 1. Hemorrhoids number 2. Caput medusae number 3. Ascites number 4. And because of back pressure on the spleen there will be also Splenomegaly number 5. Splenomegaly is also seen. It's also seen. Splenomegaly is also seen. So in a portal hypertension patient, what are all the clinical features the patient comes to you? Are these. So the most common cause of death of these cases of portal hypertension is, most common cause of death is what? Please remember, it is usually liver failure, which can be prevented only by liver transplantation. The most common cause of death is liver failure. Second common cause which we can prevent is what? Second common causes which we can prevent is varices. So second common cause is varices. Going for bleeding. That is the second common cause of death. So second common cause of death is varices, bleeding. So other important things which can cause bleeding are portal hypertensive gastropathy is another cause of bleeding. So patient coming to you with hematemesis is most commonly due to variceal bleeding, and other causes are portal hypertensive gastropathy. Portal hypertensive gastropathy is another cause of bleeding. And there are some syndromes which can happen in portal hypertension due to long run. What are those syndromes? They are known as hepatopulmonary syndrome. Please understand, because of a long run portal hypertension, they develop hepatopulmonary syndrome. Hepatopulmonary syndrome, what is seen? In hepatopulmonary syndrome, the pulmonary vessels are dilated. There is a vasodilatation of pulmonary vessels. Please don't forget this point. In hepatopulmonary syndrome, there is vasodilatation of pulmonary vessels. And there is one more similar syndrome due to portal hypertension known as portopulmonary hypertension. See, portal hypertension going for pulmonary hypertension. That is known as portopulmonary hypertension. So what happens in this syndrome is, here there is vasoconstriction of the vessels. So if there is a vasoconstriction, naturally the pulmonary artery pressure becomes more than 25 millimeters mercury. Please don't forget this. So hepatopulmonary syndrome is a condition in which the pulmonary vessels are vasodilated. Because of vasodilatation, the oxygen is not reaching the blood. So the patients have hypoxia. They will have hypoxia, platypnea. So many respiratory symptoms are seen, and this is usually diagnosed by an investigation of choice. Echo will show you the problem. Echo is used to diagnose hepatopulmonary syndrome. So portopulmonary hypertension is diagnosed by wedge pressure of the pulmonary artery. Wedge pressure is used to see, and it will be increased. Wedge pressure is increased. And please don't forget, both these conditions should undergo liver transplantation. Both these patients should undergo liver transplantation. So the treatment of both hepatopulmonary syndrome and for portopulmonary hypertension is liver transplantation. Very simple concept. There is nothing to mug up. Please remember, because of portal hypertension, if there is a vasodilatation, it is hepatopulmonary syndrome. If there is a vasoconstriction, it is portopulmonary hypertension. Which is more serious case among these two? Which is more serious? More serious is portopulmonary hypertension, because if you are not going to do liver transplantation immediately, and if the pulmonary pressure becomes more than 50 millimeters mercury, even this liver transplant becomes contraindication. If the pulmonary pressure becomes more than 50 millimeters mercury, even liver transplantation cannot be done. It is one of the contraindication of liver transplantation. So portopulmonary hypertension more than 50 millimeters mercury is a contraindication of liver transplantation. Please remember this point. So therefore, we must manage these cases seriously. In portal hypertension. Now, let me discuss the protocol. Very important protocol. Next 30 minutes is very important for you. Protocol in variceal bleed. So what are all the clinical features of portal hypertension? Don't forget, there will be ascites, there will be splenomegaly, there will be varices, there will be hemorrhoids, there will be capute medusae around the umbilicus, and there will be what else? There will be hepatopulmonary syndrome and portopulmonary hypertension. So now, protocol in variceal bleed. So among the various causes of upper GI bleed, variceal bleed is only 20%. 80% is other causes. Variceal bleed is only 20%. Of this 20%, the most common is esophageal varices. Other causes are gastric varices, portal hypertensive gastropathy are the other causes. So the most common cause of variceal bleed is rupture of esophageal varices, or gastric varices, or portal hypertensive gastropathy. And this bleeding happens when the portal vein pressure becomes how much? So when the portal vein pressure becomes more than 10 millimeters mercury, varices is formed, and when it is more than 12 millimeters mercury, varices will bleed. So please remember, when it is more than 10 millimeters, varices are formed, and when it is more than 12 millimeters, it will start bleeding. So it will start bleeding when the pressure is more than 12 millimeters mercury. So now let us discuss a protocol. You are a general practitioner. Please remember, you are a general practitioner sitting in your clinic. You are about to close the clinic. It is around 11 o'clock already night. You are about to close the clinic and go home. And you are now counting the collected money on that day. Suddenly, there is a stretcher entering your room. And there is a patient shifted to your clinic. Mr. Ramu, a known case of DCLD. He is a known case of DCLD. He is having ascites, and he is shifted to your clinic with a massive hematemesis. What are you going to do now? So it is already closing time of your clinic. A patient is coming to your clinic. Yours is a small clinic. Suddenly, a patient is shifted to your clinic. Patient is very sick, and there are so many attenders standing with the patient. So you should be now doing something. What will you do? What you should do? Either you should treat the patient or immediately change your dress and tell, sir, I am a compounder. Just now, doctor went out, so he will let us come. We will shift the patient to some other hospital. Like that, something you should do. What are you going to do for this patient now? So Mr. Ramu entering your hospital with hematemesis. So you are trying to treat something or do something. Today, in the practice era, it is very, very difficult to satisfy the attenders. Nowadays, we have to treat not the patients. We have to treat the attenders. We are getting more fear on treating the patients, like especially these type of sick patients. We are thinking 2 to 3 times before attending such patients. That has happened now because of various violences happening everywhere. So anyhow, let us see what will we do if you see a patient like this in your hospital. So the moment you receive this patient, immediately put a IV line and resuscitate and put a Rives tube. The moment you put a Rives tube, the bleeding will come through the Rives tube and he won't vomit. Put a IV line, Rives tube, Foley's catheter. So put a IV line, Rives tube, Foley's catheter. And usually general practitioners will be having an injection to put during this type of variceal bleed. What is the drug of choice for varices? Drug of choice for variceal bleed. You know he is a case of DCLD. Coming to you with hematemesis, you know he is a case of DCLD with hematemesis. So drug of choice is injection octreotide is a drug of choice. So somatostatin analog is given. So injection octreotide is given initially as a drug of choice. So this is a drug of choice, and there are many other drugs available like vasopressin, but these are all not drug of choice. Just I'm telling you other drugs. Terlipressin are all other drugs available, but octreotide is a drug of choice. Vasopressin and terlipressin can be used, and when you use these drugs, we should add up with glyceryl trinitrate to avoid coronary ischemia. So when you give vasopressin, you should add glyceryl trinitrate to avoid coronary ischemia. So give octreotide injection, and Octreotide is given in drip. So if the bleeding stops, no problem. If the bleeding stops, see, please remember, I'm just going like a story. So Mr. Ramu coming to your clinic, you are starting IV line, rice tube, Foley, everything is put. Now still the bleeding is coming in the rice tube. Immediately you start an octreotide, vasopressin or terlipressin. And there is also an MCQ for super specialty exams. What is the first drug you give in a hematemesis patient? A patient coming to you with a hematemesis, what is the first drug you give? We don't know what is that case. Just you receiving a patient. What is the first drug you give? Injection. PPI is the first drug because the most common cause of hematemesis is duodenal ulcer. So therefore, first drug given in a case of hematemesis is PPI. So if it is a varices, drug of choice is octreotide. So now you have put octreotide, still the bleeding is going on. Now you take up a tube which is there in the fridge, in the freezer compartment. We cannot keep that tube like this on the table. That tube should be kept only in the freezer compartment, like a cooker rubber tube. You have to keep it in the freezer. When you keep it outside, it will rupture. So that tube is known as Sengstaken-Blackmore tube. Now comes the discussion on Sengstaken-Blackmore tube. Sengstaken-Blackmore tube, now it is known as modified tube. The tube which we use nowadays is modified Sengstaken-Blackmore tube, which is made up of rubber. It is made up of rubber and it has 1, 2, 3, and 4 lumens, and the tube is like this. It is having 4 lumens and it is having 2 balloons. This is esophageal balloon and this is gastric balloon. There are totally 4 lumens and 2 balloons. So this is esophageal balloon, this is gastric balloon. So modified Sengstaken-Blackmore tube is used in emergency in case of variceal bleeding, which is not stopped with octreotide. Immediately insert the tube. It can be inserted through nose or mouth. You can even insert it through mouth. So you can ask the patient to swallow the tube. You can insert it through mouth or nose. Put the tube inside. First balloon to be inflated. I'm putting the MCQs on this side. The first balloon to be inflated is what? After you insert this tube, the first balloon to be inserted is gastric balloon. Using what? Using what we inflate this gastric balloon? Using air up to 300 ml, 250 to 300 ml, air is inflated. So once it is inflated, then you pull and see the tube. If it will not come up because it will exactly go to the OG junction. It will hitch at the OG junction like this. So this is the stomach. It will hitch at the OG junction. It won't come. Now you inflate the second balloon. Second balloon inflated is esophageal balloon. So please remember, the first balloon inflated through this lumen, second balloon inflated through this lumen. This will have a manometer attached here. So we will inflate it with the air of 40 millimeters mercury. Please remember, we will inflate it at a pressure of 40 millimeters mercury. That is a manometer showing you the pressure. So we will inflate it at 40 millimeters. And the third lumen is to aspirate from the stomach. So third is to aspirate the stomach. Fourth is to aspirate from the esophagus. So 4 acts here, 3 acts here. So there are totally 4 lumens. 3 acts inside the stomach for aspiration, 4 acts in the esophagus for aspiration. So we have now put the balloon. It is just producing a tamponade effect. It is producing a tamponade effect on the bleeding varices. So this tamponade effect is useful only for esophageal varices. Please remember, it is useful only for esophageal varices. It is not useful for what are the other bleeding points there. Like Dilephois lesion, it is not useful. It is not useful for what other bleeding? Mallory V star, it is not useful. Why? Why it is not useful in these two cases? Why it is useful only for esophageal varices? Because varices is a venous bleed. But these Dilephois, Mallory V's and all artery bleed, so it is not useful. The maximum time we can retain this balloon is only for 12 hours. So we can maximum retain it for only 12 hours. Within 12 hours, we should shift the patient to a medical gastroenterologist. If you retain for more than 12 hours, the major problem is necrosis of esophagus and perforation. So we should not retain it for more than 12 hours. So it is a temporary tube. You should immediately shift the patient to a medical gastroenterologist for further management. Okay, please don't forget, this is Sengstaken-Blackmore tube. Sengstaken-Blackmore tube is a high yield topic. The first balloon inflated is gastric balloon for 300 ml, and second balloon inflated is esophageal balloon, which is inflated up to 40 millimeters mercury. And this tamponade effect is only useful for esophageal varices. Maximum we can use for 12 hours. Now, Mr. Ramu will be shifted to a medical gastroenterologist. Now comes the treatment of choice for varices. A drug of choice is octreotide. Treatment of choice for esophageal varices is endoscopy and what? Endoscopic banding is the treatment of choice. Endoscopic banding of the varices is the treatment of choice. Another treatment is endoscopic sclerotherapy. Endoscopic sclerotherapy. So the sclerosants commonly used are sodium tetradecyl is commonly used. So the commonly used sclerosant for esophageal varices is sodium tetradecyl is commonly used. So please don't forget, endoscopic banding or endoscopic sclerotherapy is done. Best is banding. These are for esophageal varices. But if it is a gastric varices, we have to do endoscopically. Banding is not possible. Sclerotherapy is also not possible. We have to put a glue in the gastric varices. That is known as cyanoacrylate glue. So for gastric varices, we should use cyanoacrylate glue. For esophageal varices, we can do banding or sclerosant. Banding or sclerosant done for esophageal varices, and for gastric varices, we must put cyanoacrylate glue. So treatment of choice is this. This is the treatment of choice for these cases. And if this is failed, please remember, if this endoscopic procedure is failed, who will you call next? So the medical gas. So please remember, we are going in a protocol. So first we did a injection octreotide, then we put a Sengstaken-Blackmore tube, then we did a endoscopic banding. That is also failed. Now you call a specialist known as interventional radiologist. We call a interventional radiologist. Now we will call a interventional radiologist. What he will come and do? The interventional radiologist will come and do a procedure known as TIPS. That procedure is known as TIPS. So please don't forget, the next procedure we are going to discuss is TIPS. So what is TIPS? TIPS is transjugular. Transjugular. Transjugular, you have to put a catheter. You have to go through the SVC, transjugular. You have to go to the SVC, go to the heart. Through the heart, you have to go to the IVC, and through the IVC, you have to enter the liver through hepatic veins. You have to enter the liver through hepatic veins and keep a stent inside, intrahepatic, transjugular, intrahepatic. So intrahepatic, transjugular, intrahepatic, portosystemic shunt. Portosystemic shunt. So what we are going to do in this procedure is done by intervention radiologist. What they will do is, see, this is a liver. Let us assume this is liver, and this is the right portal vein, and this is left portal vein, and this is right hepatic vein, middle hepatic vein, left hepatic vein. So this is going into IVC. So there is full of cirrhosis inside this liver like this. So now what we are going to do is, we are going to pass a stent through this place like this, like this. We are going to keep a stent in this place like this. Intrahepatic, we are going to keep a stent. That stent is polytetrafluoroethylene stent. That stent is made up of what material means? Polytetrafluoroethylene stent is kept inside. So this polytetrafluoroethylene stent is kept between hepatic vein and the portal vein. So now what will happen? Naturally, the blood will directly flow from portal vein to hepatic vein. Therefore, the portal pressure decreases. Immediately the portal pressure decreases, and varices bleeding stops. varices bleed stops in putting at tips. So tips is done through internal jugular vein route, goes through the heart into the IVC, into right hepatic vein to right portal vein, or whichever is accessible we can put there. A stent made up of polytetrafluoroethylene stent. So it is a stent between hepatic vein and a portal vein branch, between hepatic vein and portal vein branch. So now the moment you put this stent, the variceal bleed will stop. And what are the complications of this procedure? So please don't forget the main early complication. So the early complication of this procedure is, as you are trying to put the stent, you will rupture the capsule, capsular rupture. The capsule will rupture. That is the most early complication, capsular rupture and intraperitoneal hemorrhage. So capsular rupture is the earliest complication, you should not forget. So early complication is capsular rupture. And within 1 month, what are the other complications expected? Within 1 month after putting this, we expect one another complication, encephalopathy. Why there is encephalopathy? Because the blood is bypassing the liver, directly going into the systemic circulation. Therefore, there is encephalopathy seen, because the blood is bypassing the liver and going to the circulation. So encephalopathy is because of bypassing the metabolization. So the patients will develop within 1 month encephalopathy, and also within 1 month they develop shunt thrombosis. Shunt thrombosis and shunt encephalopathy are the two important complications within 1 year. And within 1 year or a late complication, what is that seen? They develop a complication known as shunt stenosis. So this is more common than shunt thrombosis. So please remember, shunt stenosis is more common than shunt thrombosis, and usually it happens around 1 year. It's happening around 1 year. So early complications are capsular rupture. Less than 1 month you see encephalopathy and shunt thrombosis, and less than 1 year you get shunt stenosis. Less than 1 year you get shunt stenosis. And this question is 100 times asked MCQ. What is the early complication of TIPS? Is capsular rupture and hemorrhage. The capsule will rupture and cause hemorrhage. Okay, within 1 month you get encephalopathy and shunt thrombosis, and within 1 year you get shunt stenosis. Shunt stenosis. So what are the contraindications for putting a TIPS? What are the contraindications for putting a TIPS? There are absolute contraindications you should never use. So the absolute contraindication for putting a TIPS are right heart failure. So that place only we go. So we go through only the right heart. So that place you should not put. Polycystic liver disease. We can rupture the cyst and it can bleed. Polycystic liver disease. Hepatopulmonary syndrome. Portopulmonary hypertension. I hope you remember what are these two. So right heart failure, polycystic liver disease, hepatopulmonary syndrome, portopulmonary hypertension are absolute contraindications for doing TIPS. So what are the relative contraindications? Relative contraindications for doing TIPS are portal vein thrombosis. There is a presence of portal vein thrombosis. How can you do bypass? No use. So there is already encephalopathy for the patient. Already patient is having encephalopathy. That also we cannot do. And if there is a liver tumor inside the liver, there is a tumor also we cannot do. So the relative contraindications are portal vein thrombosis, encephalopathy, and liver tumor are the relative contraindications. Absolute contraindication, please don't forget right heart failure. Right heart failure is an absolute contraindication. And what is the one added advantage of TIPS? Usually it is done for stopping the variceal bleed, but there is an added advantage. There is one added advantage in this. What is it known as? What is the added advantage means? Ascites also decreases. If there is ascites, it is decreasing in TIPS. TIPS helps to reduce the ascites also. Because we are reducing the portal pressure, ascites also is decreased. So please don't forget, ascites is also decreased. Is one added advantage of TIPS. So but if TIPS facilities are not available, see, and still the protocol is not over. The protocol is not over. From you are a general practitioner, from you the patient went to a medical gastroenterologist. The medical gastroenterology, when it is not possible to stop the bleeding, it went to a radiologist. And if the radiologist is not available or unable to do TIPS, there comes a surgical gastroenterologist for doing what procedure? We come there to do shunt operations. So we come there to do shunt operations. So you have to have an idea about the shunt operations. Please don't forget. So there are two types of shunt operations. One is non-selective shunt. The shunt operations are non-selective shunt operation, and another is selective shunt operation. Non-selective shunt, the entire blood from the portal vein is directed towards the systemic circulation. So there is no metabolization in the liver. So they have the most common problem, encephalopathy. So the entire portal blood is diverted to the systemic circulation in a non-selective way. So that is known as non-selective, and they get encephalopathy. In selective shunt, we divert half of the blood, not full blood. So especially a blood coming from the splenic vein is diverted to systemic circulation. Therefore, there is no encephalopathy, but they have a problem because of increased superior mesenteric vein pressure. That is the complication known as ascites. You will understand why these complications are happening when I draw the diagram. So please understand the diagrams I am making. This is portal vein, superior mesenteric vein, splenic vein. So now I am going to show you the non-selective shunt operations by picture. So this is IVC. This is IVC. So the various operations done to divert the blood from the portal vein to IVC are, see, I can simply make a end to side anastomosis like this. See, please understand this picture. I can make a simple diagram like this. I can cut the portal vein and anastomose like this. So end to side portocaval shunt. So all the blood from the portal vein is now entering the IVC. Or else I can make a side to side portocaval shunt like this. Side to side portocaval shunt like this. See, I have made a side to side anastomosis like this. Or else I can make a stent. Interposition stent like this. 16 millimeter diameter. 16 millimeter interposition shunt I can make. I can make a 16 millimeter interposition stent I can put as a shunt. So these are all between portocaval, between the portal vein and the IVC. And please remember, already I showed you one procedure, TIPS. It is also a type of non-selective shunt. So end to side portocaval shunt, side to side portocaval shunt, interposition shunt of 16 millimeter diameter, and TIPS are all examples of non-selective shunt. Let me now show you one interesting non-selective shunt. Very important for your exam. This is superior mesenteric vein. So now I already told you this is splenic vein. This is spleen, which is already enlarged. And now this is IVC, this is renal vein, and this is kidney. So now you are going to see one important interesting procedure known as Linton shunt, also known as conventional shunt, also known as proximal splenorenal shunt. So please don't forget, Linton, conventional, proximal splenorenal are the names. What I will do in this shunt, please follow this picture I am drawing here. It is also a type of non-selective shunt. I will remove the spleen. See, I am removing the spleen in this. In this procedure, first I remove the spleen and anastomose the I will anastomose the splenic vein to the renal vein. I will anastomose the splenic vein to the renal vein like this. So this is proximal splenorenal shunt. So this is Linton shunt, and you can see the entire blood from here will now not go to the liver, will go like this and go like this into the IVC. So this is known as non-selective shunt. So non-selective shunt examples are end-to-side portocaval shunt, side-to-side portocaval shunt, interposition shunt, TIPS, and Linton shunt. Please don't forget there are 5 non-selective shunts. There are totally 5 non-selective shunts. So in which shunt splenectomy is done is in Linton shunt. So splenectomy is done in Linton shunt. So in this all non-selective shunt, you can see all the blood is going out of liver, and therefore they get encephalopathy. Now let me tell you, only one selective shunt is asked for PG level exams. That is this shunt. I am drawing that shunt. This is spleen, and the same picture, remember, this is IVC and this is kidney. This is IVC and this is kidney. Now what I am going to do is, I am going to divert the splenic vein into the renal vein like this, and I will ligate this vein here. I will ligate the proximal splenic vein, and the distal splenic vein I will anastomose it with the renal vein. So this is known as distal splenorenal shunt. In this, half of the blood is diverted away, so the portal pressure decreases. So this shunt is known as DSRS or Warren shunt. So this is the commonly done shunt by many surgeons, distal splenorenal or Warren shunt. Distal splenorenal or Warren shunt. The major drawback in this is the pressure in the superior mesenteric vein increases, and therefore the ascites may happen. Even those who are not having ascites will now develop ascites. So this is known as DSRS or Warren shunt. This is one selective shunt. So selective shunt is DSRS or Warren shunt. Though not important for PG, I am going to draw one shunt. You tell me what is this shunt. Tell me what is this shunt. So this is IVC, and all of you know what is this vein. Can you tell me what is this vein joining at the trifurcation? That is left gastric vein, which is the major culprit for varices. Left gastric vein. I will anastomose this left gastric vein with IVC. It is known as what shunt? I will anastomose left gastric vein with IVC so that the pressure in the left gastric vein will decrease. This shunt is known as Inakuchi shunt. That shunt is known as Inakuchi shunt. So left gastric vein, which is present in the trifurcation, is joining into IVC. That is anastomosed with IVC is known as Inakuchi shunt. So for your PG level, if you know the name itself, it's more than enough. Please don't forget the names. So selective shunts are Warren or distal splenorenal, and Inakuchi shunt are the selective shunts. So there are totally 7 shunt operations I have told. What are all the non-selective shunt? End-to-side portocaval, side-to-side portocaval, interposition, TIPS, and Linton are the non-selective shunts. Selective shunts are DSRS and Inakuchi are the selective shunt. So this is done by us, surgical gastroenterologists. We do these shunt operations. So now please don't forget one important scenario which can happen is if splenic vein is thrombosed, or superior mesenteric vein thrombosed, or if the splanchnic veins are thrombosed. So splanchnic vein is thrombosed. So there is no veins available. The veins are not feasible for shunt operations. At that time comes one important operation which is known as devascularization operation. Devascularization is the last operation for bleeding esophageal varices. So this is the esophagus. You all know very well. The varices are here. The varices are dilated here. So the problem is in this place. How to treat that problem? Let me ligate all the vessels which are entering the esophagus like this. All the vessels entering the esophagus will be ligated by me. So that is known as devascularization. So devascularization is ligation of the vessels entering near the OG junction. So ligation of vessels. Ligation of all veins entering the esophagus, number 1. And while I am doing that, naturally we will also cut the vagus nerve without our knowledge. Vagus nerve also will be cut. So therefore, vagotomy will be added in this procedure. And if I do vagotomy, I should always do a pyloroplasty. Please remember, I will do pyloroplasty. And along with this, I will transect the esophagus and re-anastomose. I will cut the esophagus and re-anastomosis to avoid submucosal collaterals. So esophageal transection will be done. And finally, there will be one more procedure done, that is removal of spleen also will be done. Splenectomy. So this is a neat super specialty level MCQ. For PG level, they will ask you what is the name. What is the name of this devascularization operation, which is done when there is no veins available. When no veins are available, we go for devascularization operation, and that operation contains of ligating all the veins towards the esophagus, vagotomy, pyloroplasty, esophageal transection, and anastomosis and splenectomy. The name of this operation is high-yield for PG. That is known as Sugiura operation. This operation is known as Sugiura operation. Please don't forget, it is a Japanese surgery, Sugiura operation. So now let me make that flow chart, what we did. So bleeding esophageal varices patient comes to your clinic, bleeding esophageal varices. Drug of choice, what you gave? Can you tell me what is the drug of choice? We gave octreotide. We can also give terlipressin or vasopressin. Drug of choice is failed, there is still bleeding. Then we put Sengstaken modified Sengstaken Blackmore tube. How long can you retain the tube? Maximum 12 hours. And you refer the patient to your medical gastroenterologist. What he did? He did a endoscopic banding. Endoscopic banding is failed. It is not working. Then we call the radiologist, intervention radiologist. Nowadays, there is life for more opportunities for intervention radiologists, and those guys will do a TIPS. So please don't forget, the early complication of TIPS is capsular rupture and hemorrhage. If TIPS is not possible or it is failed, we call the surgical gastroenterologist for doing shunt operations. In which shunt operation I will do splenectomy? Can you tell me? In which shunt operation I will do splenectomy? Linton shunt, also known as proximal splenorenal shunt. And the selective shunt is DSRS, which is also known as Warren shunt. If shunt operation is not possible, then I will go for a devascularization operation known as Sugiura operation. So this is the protocol in the management of esophageal varices. The protocol from Sabiston is this. Protocol for esophageal varices bleeding. You should never miss this MCQ. And what is Inakuchi shunt? Inakuchi is a shunt between left gastric vein and IVC. Is known as Inakuchi shunt. So please don't forget these protocol for bleeding esophageal varices. Next we are going to discuss each type of portal hypertension one by one. So now let me discuss the each types of portal hypertension one by one. We are going to discuss portal hypertension types one by one. So let me start with the first important type, that is sinustral portal hypertension. As the name says, it is also known as left side portal hypertension. What is this left side portal hypertension? Please understand, this is splenic vein. this is spleen, this is superior mesenteric vein. They join to form the portal vein. Now what happens in this case? The splenic vein gets thrombosed. The splenic vein gets thrombosed like this. This is splenic vein thrombosis. So because of the splenic vein thrombosis, the spleen gets enlarged, and from there the short gastric veins, which will enter into where? They will form a collateral towards stomach through the short gastric veins. They will form collaterals through the short gastric veins, and therefore they form gastric varices. So this one picture is enough to make you the entire sinustral portal hypertension clear for exam. So please don't forget, in sinustral portal hypertension, the pathology is there is a splenic vein thrombosis. Because of splenic vein thrombosis, there is collateral opened from spleen to stomach. Therefore, they get isolated gastric varices. There is no esophageal varices. So this itself is a direct one-liner. In which condition you get isolated gastric varices is in case of sinustral portal hypertension, you get a isolated gastric varices. What is the etiology for this condition? The etiology for this condition is chronic pancreatitis. So chronic pancreatitis is one of the important etiology. It is a sequelae of chronic pancreatitis. So these patients present to you with a splenomegaly, massive splenomegaly, spleen enlargement, and with isolated gastric varices. So please don't forget, they present with spleen enlargement and with isolated gastric varices. So the treatment of choice for this condition is a repeat question. What is the treatment of choice? The treatment is very easy, simple treatment. That is splenectomy is the treatment for this case. Splenectomy is a treatment for this case of sinustral portal hypertension. So splenectomy is a treatment of choice. So the point you should not forget here is this is sinustral portal hypertension is the first topic. I want you to remember in this high yield MCQ for national board exam is isolated gastric varices is present in dash. It is in sinustral portal hypertension. So two important conditions now I am going to discuss. They are NCPF and EHPVO. So non-cirrhotic portal fibrosis and extrahepatic portal vein obstruction. Please understand this. So this is the main portal vein. This is superior mesenteric vein. This is splenic vein, superior mesenteric vein, and this is right and left first order branch, and this is second order branch, and this is third order branch. So this is how the portal vein divides in the liver. So non-cirrhotic portal fibrosis is a condition in which the second order portal vein is fibrosed. Second order and third order portal vein are obstructed. Please remember, second and third order branches are obstructed. That is known as NCPF. The second order and third order branches are compressed or fibrosed. It is known as non-cirrhotic portal fibrosis. In EHPVO, the main portal vein or the first order portal vein is obstructed. Main or first order portal vein getting thrombosed or some obstruction. So please understand, these are two important pre-sinusoidal causes. NCPF, that is second and third order getting fibrosed. In EHPVO, the main portal vein and the first order getting thrombosed or obstructed. And NCPF is common between the age group of 20 to 40 years. The main age group is around 30 years. It is common between 20 to 40 years. EHPVO is common in less than 10 years. Since EHPVO is common in less than 10 years, they have stunted growth. The growth retardation is seen in these children. The children will have growth retardation. So these two are two important causes of portal hypertension. They present to you with the common clinical features. The common clinical features of both NCPF and EHPVO are they develop esophagogastric varices. Very important. They develop esophagogastric varices and that will rupture. And the most common presentation of these two cases is hematemesis. Is the most common presentation. So both NCPF and EHPVO, they present to you with the esophagogastric varices that ruptures and come to you with hematemesis. They both have moderate to massive splenomegaly. Moderate to massive spleen enlargement is seen in both cases. And the spleen enlargement is more commonly or more bigger in NCPF. It is more bigger in NCPF. But both of them will have splenomegaly. In NCPF, it is more bigger. An interesting point is, in both these conditions, liver histology is normal. Please don't forget, liver histology is normal. Therefore, LFT is also normal. And because LFT is normal, there is no ascites. So what are all the clinical features of EHPVO and NCPF are? They have esophagogastric varices, hematemesis, moderate splenomegaly, liver histology normal, LFT normal. So there is no ascites in these cases. And therefore, the treatment of these patients is very simple. So the treatment is, since there is a massive splenomegaly, we have to do splenectomy. So when you do splenectomy, what shunt will you do? When you do splenectomy, the shunt done is proximal splenorenal shunt or Linton shunt is done. So the treatment of choice for both these cases is PSRS or Linton shunt. PSRS or Linton shunt is the treatment of choice for both these cases. And I want you to remember one interesting shunt known as Rex shunt done by pediatric surgeons for EHPVO. It is a most physiological shunt. What is this Rex shunt? I'm going to draw you the Rex shunt now. So this is right portal vein, this is left portal vein. This is portal vein with the obstruction here. So let us assume this is obstruction in EHPVO, and this is superior mesenteric vein, this is splenic vein. So in Rex shunt, what I am going to do is, I am going to remove the internal jugular vein. Please remember, I am going to remove the internal jugular vein, and I am going to anastomose the internal jugular vein from superior mesenteric vein to left portal vein. I am going to anastomose the internal jugular vein. It is like a most physiological shunt. We are bypassing the obstruction. It is one of the physiological shunt, and it is known as Rex shunt, usually done for pediatric cases. Pediatric cases of EHPVO, we do this shunt known as Rex shunt. Please don't forget this name, Rex shunt for EHPVO. So EHPVO and NCPF, don't forget. So EHPVO and NCPF, please don't forget, these are two causes of pre-sinusoidal portal hypertension. Both of them will have normal liver, no ascites, liver function test is normal. Okay. And now coming to post-sinusoidal causes. What are the post-sinusoidal causes? We discussed they are intrahepatic cause due to sublobular venules getting thrombosed. Is known as veno-occlusive disease. And another one which is post-hepatic is Budd-Chiari syndrome. And veno-occlusive disease. Let us first finish about veno-occlusive disease, though not important for we just know the etiology. The most common etiology for veno-occlusive disease is usually due to following a bone marrow transplant. It usually follows bone marrow transplant. So it is one of the important etiology for veno-occlusive disease, and pyrazolidone alkaloids, chemotherapy drugs like pyrazolidone alkaloids. So please remember, the causes of this are bone marrow transplant, chemotherapy, and immunosuppressants like azathioprine. All these cases can cause sublobular venule thrombosis. Sublobular venules get thrombosed. So sublobular venule is getting thrombosed. So the treatment of choice, the drug of choice for this condition is what? This is the only question I expect for PG level, because this is a line from Sabiston. So this is a new drug which you can get in exam. This is known as defibrotide. Defibrotide is a drug of choice for veno-occlusive disease. So veno-occlusive disease is a sublobular venule thrombosis, and the drug of choice is defibrotide. And how to diagnose this condition means if you do venography, please remember, very interesting point, hepatic vein is also normal, IVC is also normal. Then what is the problem? When you have a wedged hepatic venous pressure will be increased. Wedging of the hepatic vein, wedged hepatic venous pressure will be increased. Okay, otherwise hepatic vein and IVC looks like normal. So please don't forget veno-occlusive disease. And coming to Budd-Chiari syndrome, Budd-Chiari syndrome is mainly due to two reasons. One is hepatic vein thrombosis. Hepatic vein thrombosis is one reason. Another is IVC occlusion. Please remember IVC occlusion by congenital membranous webs. IVC occlusion by congenital membranous webs. So I'm going to tell you one interesting and important point now. Budd-Chiari syndrome. The most common cause of Budd-Chiari syndrome in Western countries is hepatic vein thrombosis. In Asian countries like India is also congenital webs. So please don't forget, in Budd-Chiari syndrome is commonly caused by congenital membranous webs in Indians and Asians, and it is most commonly caused by thrombosis in Western countries. So please don't forget these 2 points. In Western countries it is due to thrombosis, in Indians it is due to membranous webs. So what is the most common cause of hepatic vein thrombosis? What is the most common cause of hepatic vein thrombosis? Can you tell me what is the most common cause of hepatic vein thrombosis? It is polycythemia rubra vera. So polycythemia is one of the most common cause of hepatic vein thrombosis. Okay, so please don't forget this point. Polycythemia rubra vera is the most common cause of hepatic vein thrombosis. Now I'm going to discuss about Budd-Chiari syndrome in detail. Budd-Chiari syndrome in detail we are going to discuss now. So please understand the picture I'm drawing. This is right left portal vein, it is normal. Superior mesenteric vein normal. Splenic vein is also normal. So everything is normal. In a Budd-Chiari syndrome, everything here is normal. Initially the liver is also excellent. Initially the liver is also normal. The problem initially is only in the hepatic veins. Initially the hepatic veins get thrombosed. Initially. So what will happen? Initially the liver will be normal, only the hepatic vein thrombosis is there. And another cause is the hepatic vein will look normal and there will be a thick membranous web. The IVC is having a thick membranous web like this, or a thin membranous congenital web like this, which is obstructing the outflow. So these are the two causes. Cause number 1, hepatic vein thrombosis. Cause number 2, IVC obstruction. And as days goes on, because of back pressure, the liver gets cirrhosis like this. And because of cirrhosis, the portal hypertension develops. And because of portal hypertension, as usual, all problems will happen, like ascites, varices, everything will happen, splenomegaly, everything will happen. So how to diagnose this Budd-Chiari syndrome? Investigation of choices. The gold standard investigation is hepatic venography. When you do hepatic venography, you will find an appearance known as spider web appearance. I will show you this image. Spider web appearance is seen in Budd-Chiari syndrome, known as spider web appearance. And when you take CT scan for these patients, CT scan will show you enlarged caudate lobe. So I told you already, caudate lobe has a direct drainage. So there will be caudate lobe hypertrophy, and it looks like hot spot. So caudate lobe looks like hot spot in CT scan. So please don't forget, hepatic venography will show you spider web appearance, and CT scan will show you hot spot on caudate lobe hypertrophy. So this point you should not forget. In Budd-Chiari syndrome, what are the findings in investigation? So now the management of Budd-Chiari syndrome depends upon the situation the patient comes to you. So please remember, depends upon the situation the patient comes to you. Management. First point, please remember, there is no use of thrombolytic agents. I want you to remember this. By giving a thrombolytic agent, we cannot remove the hepatic vein thrombus. It is already well formed. So no use of thrombolytic agents. Please remember this. Therefore, if the liver is normal, I should immediately plan for a shunt operation. If liver is normal means there will be no ascites, LFT will be normal, only there will be esophageal varices or mild splenomegaly will be there. So I will plan a shunt operation. What shunt operation I will do? Especially what shunt operation I will do means if it is only a hepatic vein thrombus. So please remember, this is IVC. If there is only hepatic vein thrombus like this, I can do one simple procedure in which I can do a side-to-side portocaval shunt. Procedure is a simple procedure. So by just doing a side-to-side portocaval shunt, I will divert the blood like this and the varices and all will disappear. But this is possible only when the liver is shunt operation, when liver is normal liver, and the case is a case of hepatic vein thrombus. But if it is a case of IVC web, what I will do? If it is a case of not hepatic vein thrombus, but if it is a case of IVC web like this, what I will do? If I do side-to-side portocaval shunt, it is not enough. Side-to-side shunt is not enough. So what I should do? Along with side-to-side portocaval shunt, I should also do one more shunt. That is, what is it? I should do a shunt from IVC to the right atrium like this. From IVC to right atrium, I should do a shunt like this. What is the name of this shunt? So this is known as cavo-atrial shunt. So for a patient with Budd-Chiari syndrome and IVC occlusion, I will do double shunt. This is a AIMS question. So what are the double shunt done for Budd-Chiari syndrome with IVC obstruction? With IVC obstruction, what will you do? The answer is side-to-side portocaval shunt with cavo-atrial shunt will be done. So please remember, now the blood will flow from here to here, and from here it will go to the atrium like this. So this is a classical point. Is there any other option? Yes, we can also do one more procedure here. We can cannulate this IVC. And we can put a stent like this if possible. If you can put an IVC stent, only side-to-side portocaval stent plus IVC stenting can also be done. But it is mostly impossible. Okay. And these are all things to be done if liver is normal. Please remember, if liver is normal, only for hepatic vein thrombus, I will do side-to-side portocaval shunt. And for IVC obstruction, I will do side-to-side portocaval plus cavo-atrial double shunt. If liver is cirrhotic, if liver is already gone for cirrhosis in Budd-Chiari syndrome, the only treatment is liver transplantation. If liver is already cirrhotic, we should go for a liver transplantation. Please don't forget this point. So if liver is already gone, we have to plan for a liver transplantation for these cases. So please don't forget this point about Budd-Chiari syndrome. So Budd-Chiari syndrome, can you clinically differentiate? I'm just asking one clinical question. Clinical method to differentiate whether it is hepatic vein thrombus alone or IVC obstruction. Can we clinically find this from the patient? By just seeing the patient, we can find it out. Yes, can you find it out or not? I'm going to show you one image of this. Yes, you can easily find out. Please remember, if there is an IVC obstruction, you can see there will be multiple collaterals running from down to upwards like this. Some superficial collaterals you can see on the abdomen wall for IVC obstruction cases. In hepatic vein thrombosis, you don't see such type of collaterals. So in IVC obstruction, we have multiple collaterals running on the abdominal wall. So these are the points you should not forget from portal hypertension. Let me show you the images of these topics now. So please don't forget the various sites of collateral. Can you tell me what is the collateral in this place? Esophagus. It is between accessory hemiazygous vein with what? With left gastric vein, also known as coronary vein. It is the collateral here. That is the one which is going to cause rupture and esophageal variceal bleed. Okay, so please don't forget esophageal collateral between accessory hemiazygous and left gastric. So anal canal, umbilicus, barrier of liver, retroperitoneum are the other places we have the collaterals. So on complications of portal hypertension, I told you the most common cause of death is hepatic failure, and in hepatopulmonary syndrome there is vascular dilatation, and in portopulmonary hypertension there is vasoconstriction. For both of these cases, liver transplantation is a treatment, but if the pressure is more than 50 millimeters, liver transplant also is contraindicated. So this is a high yield image based question. So the second Blackmore tube, modified tube, you can see 1, 2, 3, 4 lumens. This is esophageal balloon which we inflate for 40 millimeters mercury, and this is a gastric balloon we inflate 300 ml of air. Both we are using air only now. We are not using normal saline now. For both inflation we use air nowadays. So you can see it is inflated like this, and this is the tips between right hepatic vein and the right portal vein. Tips is done by interventional radiologist. You can see this radiology picture, and this is the polytetrafluoroethylene stent. It is made up of polytetrafluoroethylene stent. And for pouring into the liver, we use a special device known as Viator device. So to pour into the liver, we have a device known as Viator device to enter the liver and put the stent. So not essential for PG, maybe used for super specialty. Viator device. Okay, so please don't forget shunt stenosis is more common complication, and usually it happens at around 1 year. So early complication is capsule rupture, and we have discussed the absolute contraindications are right heart failure, polycystic liver disease, pulmonary hypertension, and hepatopulmonary syndromes. So we have discussed various shunt operations. So don't forget what is the other name of conventional splenorenal shunt. It is also known as Linton shunt or PSRS shunt. What is the other name of Warren shunt? It is DSRS shunt. It is DSRS shunt. So please don't forget Sugiura operation. Sugiura operation, which I told you, this is a devascularization operation which we do splenectomy, pyloroplasty, truncal vagotomy, esophageal resection and anastomosis, transection and anastomosis. All these things are done in Sugiura operation. So I discussed about the differences between NCPF and DHPVO. Please follow that, and don't forget the common features. There is no ascites. There is only the common presentation, variceal bleeding. There is splenomegaly, normal LFT. So these are common points. And this is a Rex shunt between superior mesenteric vein and the left portal vein. Superior mesenteric vein to left portal vein. This is the Rex shunt. So please don't forget veno-occlusive disease is most common in bone marrow transplant patients. Bone marrow transplant patients, and the drug of choice is defibrotide is the drug of choice. Okay, defibrotide is the drug of choice, and if at all surgery needed, we do side-to-side portocaval shunt in these patients. So this is the typical patient with the IVC obstruction, Indian patients. You can see the dilated veins running on the abdomen wall. This patient is having ascites, so he is having a cirrhosis of the liver. This patient is having normal abdomen, so no ascites. So this patient is an ideal patient for side-to-side portocaval shunt plus cavoatrial shunt. This patient is an ideal patient for liver transplantation. So both are my patients. With this patient we did a double shunt, side-to-side portocaval and a cavoatrial shunt, and for this patient we refer the patient for a liver transplantation. Okay, please remember Bucchiari syndrome in India is usually due to IVC webs. Okay, and this is a spider web appearance seen in hepatic venography like a spider web. This is the investigation of choice for Bucchiari syndrome. Okay, so I told you non-cirrhotic patients, only we can do side-to-side portocaval shunt. Cirrhotic patients we do liver transplantation, and especially if there is an IVC obstruction, we should do double shunt, side-to-side portocaval and cavoatrial shunt. So Rex shunt done for EHPVO. Erection done for EHPVO between superior mesenteric vein and left portal vein. And where will you do cavoatrial shunt? It is for Bucchiari syndrome. Okay, so that's about the portal hypertension. So portal hypertension is an important topic. Just have these all points. It will help you in also medicine. Okay, thank you.